Dr. Mohammad Al Haddad, the Director of Gastroenterology and Pathology at Indiana University, a well-known a gastroenterologist expert. And Dr. Mohammed will answer if the artificial intelligence can help us to solve the dilemma of diagnosis of indeterminate biliary stricture.
Thank you, Dr. Nawaf, Dr. Ahmed. Assalamu alaikum wa rahmatullah. I'd like to thank Dr. Imad for the kind invitation for the second year. It's been an honor to be part of the organizing committee of this very successful conference. MashaAllah, we've seen tremendous growth in the scope of presentations and the audience turnout, as well as industry support. Thank you very much again for this kind of introduction. And I think, let me see if I can advance my slides. Okay, there we go. So I'm going to first try to introduce the concept of indeterminate biliary stricture before I tell you how we can solve this dilemma. But in 2025, the truth of the matter, we continue to struggle with identifying the underlying cause of strictures, and approximately 1 out of 5 strictures that remain indeterminate after imaging, and as well as ARCP and brush cytology. Obviously, delayed diagnosis can lead to missed opportunity to provide curative care, but also you don't want to provide, put someone through surgery if they have a benign disease. So this is still a dilemma for many of us, and our oncology colleagues and surgeons still require a pathological diagnosis before they can expose someone to very radical therapies. Our long-term trusted friend in ERCP and brushings essentially is only sensitive in about 30 to 40% of the time. Unfortunately, fibrosis, dysplasia does muddy the picture, and often imaging is good but not sufficient in terms of providing a diagnosis. So we almost always have to go deep and dig into the additional techniques and tools that we have to be able to accurately diagnose a stricture of this type. And as good as imaging has gotten to be in the last 15 to 20 years, we can still stage these lesions in terms of local extension, metastasis to lymph nodes, vascular involvement, and the volume of the tumor. However, we cannot make a pathological diagnosis based on that, and we still need the intervention, i.e. the drainage in a biliary stricture. So ultimately, we go back to endoscopy. Why the struggle? Because these inflammatory strictures, malignant strictures, and extrinsic compression come from a variety of backgrounds, which are not a single pathway to the same or the single outcome, which is a biliary stenosis. So it could be pancreatic cancer, cholangiocarcinoma. It could be autoimmune inflammatory. It could be ischemic. As you can see, there's just a slew of possibilities on the diagnostics of indeterminate biliary strictures. And as good as an endoscopist can be, you can judge a malignant from a benign stricture just by looking at fluoroscopy images, which is fantastic. The reality is that this doesn't always provide you the answer. And often you're fooled by for example, 2 completely different pathologies giving you the same picture, which is a hilar stricture, bismuth 4 type of stricture, one coming from a cholangiocarcinoma and one coming from IgG4 cholangiopathy. So even the most skilled advanced endoscopists can be fooled by the appearance on imaging and on fluoroscopy. So this is why we have to go deep and search in the toolbox for what's out there. And the 2 things where they have passed the test of time, brushings and forceps biopsies, can be combined. It probably is a wonderful first-line diagnostic test in biliary strictures. And as you can see, this is the ASGE guideline published a few years ago. I had the pleasure to work on this guideline with several colleagues within the ASGE. And the truth of the matter is, even when you combine both brushings and pathology from biopsy forceps, you're only getting up to about 50 to 60% sensitivity. And I keep talking about sensitivity because we're typically concerned about missing a cancer. That's why sensitivity matters. It matters the most because you don't want to miss a cancer, and this is where sensitivity delivers back to you. So what else can we go to? We have to tap into additional techniques. For those who have access to fluorescence in situ hybridization, we use it in the US, or we used to, not as much now since we have other additional techniques and technologies, but it often will tell you if there is a brushing or a stricture that you have brushed several times, it keeps coming back negative, and you find a positive fish. Typically it's aneuploidy or polysomy. and you can probably at this point move the care forward and not continue to bring the patient back for repeated sampling. But again, it's expensive, it's not available everywhere, and sometimes it can be false positive in inflammatory strictures, especially PSC. EUS is a wonderful tool for distal strictures. It shows you biliary, pancreatic, and extrinsic compressions in terms of malignancy. Fine needle biopsy comes with 85 to 90% yield rate. So it is a wonderful tool to add. And I highly recommend combining ERCP and EUS in tandem. If you have a distal biliary stricture, you maximize your tissue sampling capabilities in one session and do not expose patients to multiple treatments. However, there's always a risk of needle track seeding if you're sampling a hilar stricture in a patient who could potentially, under very strict liver transplant protocols, like the Mayo protocol, for example, you may be exposing this patient to risk of seeding. So this has to be done in obviously in a multidisciplinary fashion. And this is where I think, I hope this is a nice segue to talk about cholangioscopy, which has really dominated the field in the last 10 to 15 years. And this is a timeline for where this came from. This is not a new concept. We've had these baby scopes for a very long time. Scopes going up in the bile duct for over 4 or 5 decades. Initially in the mother-baby concept that you're all familiar with, and subsequently through the fiber optic small scopes in 2007, which was a precursor for the new digital single operator cholangioscope in 2015. And now we have multiple companies providing several new platforms for digital single operator cholangioscopy devices on the market. And in about the last 3 to 4 years, we've kind of done a sort of a more extensive look into how AI can help us determine what type of stricture we're dealing with based on digital cholangioscopy images. What is the ideal cholangioscope? You want one, obviously, with high resolution, one that has sharp images, good illumination, very good bendability and maneuverability. You want a scope that's stable in the duct, does not slide in and out of place. You want also a large diameter for accessory channels, so you can pass wires and sampling devices and other tools, and you want obviously to be cost effective. Obviously, we're not quite there, but we're making good progress in this. Over the last few years, technology has moved on to the point where we can definitely say that this video is not working, but I was going to show you how this looks like under the, thank you so much for working that. Digital systems now offer high definition imaging with targeted biopsies and interventions, passing wires, and a single endoscopist will control both the duodenoscope and the cholangioscope simultaneously without needing any additional assistance. So we can do a whole lot of things now with cholangioscopes, from looking at strictures to staging tumors, looking at intraductal extension, being able to tell how far up the tumor goes in the duct, evaluation of stones, but also managing complex stones and applying therapeutic interventions to fragment these cones and target tumor therapy with RFA and access complex biliary strictures through direct passing of wires above the strictures and removal of foreign bodies. Cholangioscopy does improve the ability to classify an indeterminate stricture. If you look at this same guideline I referenced earlier, ERCP with cholangioscopy brings your sensitivity to the low 60s. If you add the cholangioscopy component to ERCP and all other tools, you're in the mid 70s. So that's a palpable increase in a very difficult cohort of patients, obviously. The question remains, do we have agreement on what looks like a malignant stricture or not? And this is where we have a few classifications that have surfaced in the last 5 years to tell us what looks like malignancy, what looks like a benign stricture. For example, this is one, the Mendoza classification led by Michel Cajale and colleagues that looked at specific phenotypes and attributes of these strictures. For example, the one I think probably stands out the most is the presence of tortuous and dilated blood vessels, nodularity, papillary projections, raised and bulky type of changes, irregular surface, ulcerations, and friability. And as you can see, among expert endoscopists, you have a fairly good to excellent agreement on what a feature looks like and its correlation with malignancy. Two other systems came out. One, championed by Dr. Carlos Robles Miranda, the CRM classification you see to the right of the screen, and also the Monaco classification. Both use very similar attributes to these, the endoscopic video appearance of these strictures, and have placed different weight on the different features, whether it's ulcerations, scar tissue, or presence of projections and abnormal blood vessels. So regardless of what system you look at, the fact that we can all agree that there are some malignant features with very good reproducibility tells you that we can teach this to a machine, right? And the machine will deliver back even a higher accuracy of prediction of malignancy. And this is the basic concept of all the LLM type of models out there predicting the risk of malignancy in a biliary stricture. And the consensus now is that you have the high yield features: irregular and dilated blood, tortuous vessels, ease, oozability, irregular surface, and papillary projections. And you have on the other end of that spectrum a whole bunch of benign features, such as smooth surface without neovascularization and homogeneous appearing mucosa without a mass. And you can, through a series of thousands, if not millions, of still pictures, train a computer to look at these and consistently provide you an education on these through the machine learning process. So this is basically the concept of AI use in indeterminate biliary strictures. You teach the machine how to accurately classify these based on still images, videos that have confirmed pathological correlation with them. This is the concept of deep learning or convoluted neural networks that provide you back data in terms of obviously being a non-invasive technique. It's objective. It has typically a high negative predictive value, so you rule out malignancy effectively in this case. And for example, in this specific study, you can achieve very high sensitivity and excellent specificity with an area under the curve of 0.9 if you teach this model through a large number of videos how to classify a stricture. It obviously exceeded that of brush cytology and that of forceps. And in fact, this specific study showed that the model performs as well as a very experienced biliary endoscopist in terms of predicting malignancy. And now you can obviously create what they call heat maps. Essentially, you color code the probability of malignancy through this digital system. Red means cancer, blue means inflammation, yellow is sort of normal, or yellow to orange. And now you take, you superimpose that on your digital colonoscopy picture or cholangioscopy picture, and you can live, during the case, predict the probability of malignancy. So basically, like we see in colonoscopy, you have this box that shows up on the picture, showing you that this is an area of an ulceration. This is an area that has abnormally dilated and tortuous blood vessels. Please focus on this area, magnify, look further, and potentially this should be the site of targeted biopsies. So I think it helps drive the attention to areas of interest, pretty much like what we see in colonoscopy. Again, another heat index view of several biliary strictures that focus on specifically in the first case papillary projections and abnormal blood vessels in the other two. And this is the performance of this specific model. You can see a very large area to the left of the neutral line on this ROC, telling us that these models actually perform very, very well and even ahead of pathology in terms of cytology and forceps biopsy. The problem remains that we only drive decisions based on pathology. So you can predict whatever you want to predict. Ultimately, you're not going to put a patient through a complex resection or expose a patient to neoadjuvant therapy or adjuvant systemic therapy, except if you have some pathological diagnosis. So pretty much like we saw in colonoscopy, is CADEX or an impression based on on AI enough to replace pathology in the future? The answer is we don't know. It is possible, but for the time being, this becomes an adjunct tool rather than a replacement to pathology. This is a new ESG guidelines. It's a pleasure to have Dr. Facciarusso right here sitting in the front, actually the lead author on this guideline that shows that we continue to use AI when and after the other tools fail to provide an answer, the traditional tools basically of sampling. In the distal strictures, highly recommend ERCP and EUS in combination. In the proximal ones, you can add EUS after ERCP has been done and has not been conclusive. And in both cases, you add another layer of cholangioscopy once you have gone through this exercise and have not gotten an answer yet for an inconclusive or indeterminate biliary stricture. So it's there due to cost, obviously. This is not something you want to do in the first line, except in very specific scenarios. And generally speaking, this is one thing that you would have in your back pocket for the indeterminate strictures after your initial evaluation has been negative. This is what we do at our institution. We're very big on combining ERCP and EUS, deploying all the tools you have from the first session so you don't have to bring the patient back again. We obviously use cytology, brushing, fish, and even obviously IgG4 and single operating cholangioscopy. If we find malignancy, you move forward. If not, you bring the patient back and you repeat sampling one more time. And this is where you can reach out to esoteric things and rarely used technologies like confocal laser endomicroscopy or introductal ultrasound. Very, very niche type of cases that require that you go this far to be able to confirm malignancy. And this is where I think we could use the help of AI as we do more image analysis. And this is where we might transition away from radiation, and maybe ultimately in the next 10, 15 years, we would be doing fluoroscopy-free ERCPs, right? Pretty much like what we went away from colonography to colonoscopy over time. This could transition away from radiation to a radiation-free type of ERCP with the help of AI. Thank you so much for your attention. I hope I stayed on time. I went over just by 1 minute, and thank you again for the invitation.
Thank you. Thank you, Dr. Haddad. And we'll just allow for 2 questions for the sake of the time.
Excellent, Mohammed. Very nice presentation. I always say for general ERCPs, for general gastroenterology, you do ERCPs in a stone passer, you know, like hemolytic anemias, sicklers, and you see a distal small stricture, 1 centimeter. Is that because stones are passing frequently? And you wonder, you do the cut and you extend the cut, still there is 1 centimeter, you feel there is a stricture. Do you ignore it? I don't have a cholangioscope, for example. So do we, or we just follow it, or what?
It depends on what your pretest probability for that stricture is. Often in this case, it's
when do you worry about the length of the distal stricture? More than 1 centimeter?
I mean, 1 centimeter distal, and you're again the chances of finding malignancy there is quite low. Strictures and stones coexist frequently. That's a common problem ultimately. At a minimum, I would probably want to sample it somehow, brush it, and potentially follow it up. But I don't know if I would be very worried about this in terms of, and even if you wanted to deploy a cholangioscope in very distal strictures, it would be very hard to see how that looks like. So I think your approach works as well, which is a combination of sampling and clinical follow-up.
I try to extend the sphincterotomy as much as I can. Maybe it will sort out that stricture.
Dr. Mohammed, this is a great point that welcome, Dr. Mohammed.
Thank you.
It's an excellent, elegant talk as usual. This is a very important point that I would like to just have a comment on it. We have a lot of patients with sickle cell disease. We see it a lot. They are young and they are stone passer, as you said, and they will have definitely distal narrowing and stricture. So I advise my colleagues not to call it a stricture. So please, when you call it a stricture in your report, you will put the patient into a big dilemma that has no indoor. So I would carefully not to label it as distal stricture. You can call it distal narrowing, likely related to stones, but the chance that this stricture is malignant, the chance that this stricture needs to go through the workup of CBD stricture is almost
Very, very small.
negligible.
I agree with that.
Thank you, Dr. Haddad.